Hello and welcome to the third presentation in our 6-module series in the Build a Clinic program on key components for implementing tobacco-free policy, including tobacco services. My name is Jim Pavlik and I'm the Program and Policy Analyst at the Behavioral Health and Wellness Program and the Program Manager for the Build a Clinic. Today we will be talking about the use of motivational interviewing to support tobacco cessation. Before we begin, I just want to cover a bit of housekeeping. You may have been misled by an erroneous message saying that if you want to hear today's audio, you should be dialing into our phone number. That is not true. This is our very first webinar without that option. We're going computer only. We're hoping that resolves a lot of the sound issues that we've been having in previous webinars if you've attended those. But we do, on that score, want to encourage you to mute your computer microphones, not your speakers as it says here, but your microphones. That'll just help you deal with feedback. And then if you want to communicate to us, all you have to do is up in that upper right-hand corner, you should see a control panel, and you can use either the raise your hand function, in which case we will unmute you and you can talk to us directly, but preferably you'll actually just use the chat function and chat to me directly with any questions you have throughout the webinar. If you do close out of the webinar accidentally, or if you get kicked out for some reason, just refer back to the email or whatever method you used to log in today to reconnect with us. If you're having any other technical issues, please contact our administrative assistant, Sarah Mumby, at the number shown here, area code 303-724-6327, and we'll get you hooked back up. That's it. And then we'll move on to me. I'm Jim Pavlik, the Program and Policy Analyst at the Behavioral Health and Wellness Program. I'm also the Build a Clinic Learning Community Program Manager. I've worked in public health and policy for 10 years in various capacities, including physical activity promotion for the Indiana Department of Health and emergency preparedness and response for the U.S. Department of Health and Human Services. Currently, I perform program evaluations for BHWP and its partners and clients, and I'm also one of its lead trainers with a focus on organizational tobacco control programs and technical assistance. I will be off in the corner in that upper right-hand box under chat, awaiting any questions you might have. Today's presenter is Dr. Cindy Morris, a clinical psychologist and the clinical director here at BHWP at the University of Colorado Anschutz Medical Campus School of Medicine. As clinical director at BHWP, Cindy directs the Wellness Leadership Institute, through which we offer many training programs and educational resources for administrators, healthcare providers, and peer specialists focused on health behavior change for whole health, work and well-being, tobacco cessation, and weight management. Today's presentation is the third in a 6-module series covering the knowledge and skills and practices that practices need to know to efficiently and effectively integrate tobacco cessation services and supports into their current clinical workflows, with a special emphasis on serving rural or otherwise underserved populations. These webinars take place monthly. We have already gone through the very basics of tobacco cessation services, including the use of the 5 A's, and last month we covered pharmacotherapy. Both of those webinars are available at our website, bhwellness.org. Look for the Materials tab, and under Materials, look for the Build a Clinic materials. This webinar will also be posted there 2 weeks from today. After today's presentation, we will discuss workflow and how tobacco cessation fits into a typical clinical workflow to find low-burden ways to integrate tobacco cessation interventions into existing practice. In the 5th month of Build a Clinic, we introduced the whys and hows of tailoring tobacco cessation interventions for populations specifically targeted by the tobacco industry and those populations that, although maybe not specifically targeted, tend to lack the preponderance of services that frequently lead to more successful quit attempts. This presentation will focus on cultural sensitivity and how the use of motivational interviewing can make clinicians more adaptive in the face of our increasingly more diverse and ever-shifting populations. In this webinar today, we will explore ways to enhance behavior change by using the MI approach, the motivational interviewing approach. Cindy will discuss motivational interviewing and talk about why an MI approach will support the tobacco cessation work you do in your practices. Then she will talk about specific MI strategies to enhance motivation and encourage commitment to change. The clinical guidelines for treating tobacco use and dependence states that although both counseling and medication are effective when used by themselves for treating tobacco dependence, the combination of counseling and medication is more effective than either alone. So clinicians should encourage all individuals making a quit attempt to receive both counseling and medication. The reason that counseling and medication together are more effective at treating tobacco dependence is because tobacco dependence itself has 2 parts. Pharmacotherapy addresses the first part of tobacco dependence, the physical addiction to nicotine, whereas counseling addresses the second part of tobacco dependence, the habit or behaviors surrounding tobacco use. We'll be focusing for this presentation on the right half of this figure, that is, the motivational interviewing approach to address behavior change. And with that, I'll turn it over to Dr. Cindy Morris.
All right, thanks, Jim. Hi, everyone. I'm so glad to be with you today to talk about motivational interviewing, or MI. Motivational interviewing is really core to the work I do to support health behavior change, especially around tobacco cessation. You know, on the surface, MI looks like the simplest approach. However, I found that it can be really challenging to consistently work from this approach, since it sometimes goes against our natural inclination to want to help people fix things, right? So hopefully what we talk about today will support you in your practice. So let's begin with the definition for MI. Motivational interviewing is a collaborative conversation style for strengthening a person's own motivation and commitment to change. It is a patient-centered guiding method to enhance intrinsic motivation by exploring and resolving ambivalence. The last line on the slide here is really key to successfully using this approach. It's really a way of being versus doing. And as such, the focus of MI is to enhance motivation. It's not about taking action. Let me say that again. It is not about taking action. While the act of stopping tobacco use is the desired outcome, it cannot be the sole focus of the conversation. People really need to prepare themselves to take action. And remember, when someone is really ready to make change, they will find a way to get it done. The work we as providers need to do is to help them get to the state of readiness. Now, a key aspect of MI is to have the right heart set. Just as the correct mindset is needed to apply MI techniques, the right heart set is needed as well. This involves approaching people with the underlying perspectives of partnership, acceptance, compassion, and evocation. Partnership involves engaging individuals in active collaboration. The MI approach involves exploration rather than telling, interest and support rather than persuasion and argument. MI should be more like dancing than wrestling. And this can be a real paradigm shift in medical settings where the norm and expectation is that the patient will be told what to do. Acceptance includes interacting in a way that communicates the inherent worth and potential of every person in a non-judgmental manner. This can be demonstrated through accurate empathy, which means being able to understand a person's experience from their perspective and communicating it to them. Compassion requires promotion of a patient's welfare by making their needs and well-being the priority. And finally, evocation involves discovery of and focus on an individual's strengths and resources. So the primary goal of MI is to interact with the person in a way that increases motivation to change and evokes change talk. You may ask, what is change talk? So change talk is any statement made by a person that indicates they are favoring making a change. An example of this, for instance, is a person talking about ways in which stopping tobacco use will improve their life. Now, before I move on to talk more about MI, I'd really like to tie this information into the 5 A's and stages of change. Since many of you are familiar with these models and will use them in your tobacco cessation workflow, I want to be sure we are all on the same page about when to use MI. First, let me say that in my experience, there are 2 ways in which I use MI skills. One is as a way to effectively communicate. This is in a broad sense. So using MI skills and strategies in your regular conversations can facilitate an interaction in which a person feels heard, validated, and truly understood. The other level is to use it as a way to motivate an individual towards change that they may not be currently ready for, such as quitting smoking. In this case, as you see on the slide, when you get to the third A, or assess, and the person is either in the stages of pre-contemplation or contemplation, you will want to use the MI approach to increase their motivation to change. And then you may or may not decide to move on to assist and arrange, depending upon the person's readiness to change after your MI conversation. Now, if during your assessment the person is in preparation, action, or maintenance stages, there is no need to use the MI approach except in the way that MI skills encourage good communication. You can work with them to set SMART goals and create an action plan. All right, moving on. There are 4 central processes to MI. These include engaging, focusing, evoking, and planning. In the next several slides, we will review each of these processes in detail. Engagement is a process that can take minutes or months to establish. If a person is engaged, they will share their thoughts and experiences with you, listen to your ideas, and return for treatment. If a person is not engaged, they will have trouble opening up and may discontinue meeting with you. Some of the things that can interfere with engagement are: 1, focusing too much on assessment. You know how responding to one question after another can be overwhelming for patients, and it can feel more like an interrogation than a conversation. Or 2, talking about how to fix the problem before there is an established relationship. When this happens, the person can struggle with feeling understood and cared for. Or 3, acting like an expert. This can cause a patient to feel disempowered or disengaged from the process. With this, they are forced into the position of taking in information, but not really actively engaging and participating in the conversation. Or finally, 4, placing the blame on the individual. In this case, the patient can feel wrongly judged and criticized. It is important to work in collaboration with people. Create a partnership that is active and facilitates a joint decision-making process. There is no room for hierarchies here. We are all human beings doing our best to live well. We all experience successes, failures, and challenges along our journey. It's helpful to use collaborative language, such as we versus I or you. Statements like, "We can do this together," or "How can we support you as you move towards living tobacco-free," can really facilitate engagement. And when collaborating with others, it's important that you understand the person's motivation. Why do they want to change? Show interest in their concerns, values, and motivations. This sounds like it could take a long time, but it really doesn't need to. It is also time well spent. Asking instead of telling is much more effective in the long run. It is also important to listen to the individual. As you practice MI, you will sharpen your listening skills. It is often not what people say that is informative. It's the specific choice of words, hesitations, eye contact, facial expressions, and the body language they use that will tell you what the person is really saying. It is also imperative that you resist what we call the writing reflex. The writing reflex is an automatic correcting reaction to something said that really doesn't fit the provider's view of a situation. For example, instead of saying, "You need to stop smoking or your health will get worse," You want to say, how do you feel about your smoking? When we see a person going down what we think is the wrong path, it's tempting to want to tell them it's the wrong path, so they'll get on the right path. But you'll really want to resist that temptation. Now let's move on to focusing. Focusing is finding one or more specific goals or intended outcomes that provide direction for consultation. The focus can come from the patient, the provider, or the context. And the patient should really be the one to decide what they want to change. While it is helpful to guide the focus of the conversation, it is important for individuals to choose their goals freely and only offer advice after you have asked and been given permission. Now think about your typical approach. Are you a director, guide, or follower? A director is someone who tells people what to do. A director evaluates, judges performance, and oversees the consequences for a job well or poorly done. Basically, a director communicates, I know what you should do and how to do it. Conversely, a follower is a good listener who takes an interest in what others have to say and respectfully refrains from adding their own views and opinions. A follower communicates, I trust your own wisdom, will stay with you, and will let you work this out in your own way. Motivational interviewing is a guiding style, which is between directing and following. Guiding promotes a collaborative process to determine direction or goals and makes use of both the provider and the individual's expertise. A helpful metaphor to understand the guiding process is that of a mountain guide. Imagine you are climbing a mountain for the first time and are in unfamiliar terrain. What type of person would you want to lead you? One who watches your every move and doesn't allow you to veer from the prescribed path? How about someone who follows you around in circles? Or someone who is right in the middle, open to exploration and aware of the pitfalls and obstacles along the path? This is a guide. Now on to evoking. With any decision to change, ambivalence is an important part of the process. The discomfort people feel when they are ambivalent can help to propel them into action. And when speaking with someone about changing their behavior, pay close attention to their ambivalence, which is reflected in a mixture of talk that supports both change and staying the same. The evoking process is meant to help resolve ambivalence in the direction of change. Each person has it in them to change, and you can help people by finding it together. You can do this by asking evocative questions or using summary statements. For example, it sounds like you want to stop smoking and are interested in what you can do. You may want to use a ruler, which we'll discuss later, or you may observe the discrepancy between their beliefs and values and their health behaviors. An example of this is, being a healthy person is a key part of your identity, and smoking just doesn't match who you want to be. The planning process builds on the same skills used in engaging, focusing, and evoking processes. The task during planning is to elicit a change plan from the individual. The more specific the goal or plan and the steps towards it, the easier it is to observe progress. In this process, it's important to respect a person's autonomy, hold open space for people to make mistakes, explore paths that may not work out, and experience the freedom to change what they want. As you are assisting patients, you may want to avoid being attached to any specific outcome. Each person's path will look different, Hold open space for unique strategies that match the needs of the person in front of you. Remember, the steps they are taking are not necessarily what you would do, nor is it often the shortest or most efficient path. It's whatever process each individual needs to get ready to change. For some people, when they see that they have not moved in the positive direction towards their goal, they can lose hope or feel embarrassed about their lack of progress. At this point, it's important to remind them that behavior change is a process of movement and stillness. It is in reflection that we often find our understanding of what we need to achieve our goal. In this next section, we will discuss specific MI skills and strategies. First, let's review the core interviewing skills, or ORs. We have open-ended questions, affirmations, reflections, and summaries. Let's look at these one at a time. Open-ended questions are questions that require a longer answer. They are not simple yes or no questions. They cannot be answered with a single word. Although you cannot avoid closed-ended questions altogether, you want to limit your use of them. Open-ended questions help to explore a person's experience, encouraging them to tell a story or come up with a thoughtful answer. They are conversational door openers and help maintain a person-centered conversation. Now I'm going to show you a couple of closed-ended questions, and I want you to think about how you would rephrase them to turn them into open-ended questions. So the first question here is simply, do you want to quit smoking? Think about what you need to change to make this question an open-ended question. So do you have your answer? Here's one that I came up with. How do you feel about quitting smoking? Now let's try another one. You do know that smoking is bad for you and your child, don't you? How can you turn this one into an open-ended question? So here's mine. What do you know about the health effects of smoking on you and your child? Do you see how just the shift in that question really feels differently when someone's saying it? Now let's look at affirmations. When a person feels supported, appreciated, and understood, they're more likely to engage in the change process with you. It feels good for them to work with you, especially when you celebrate the steps they take, no matter how small, towards tobacco cessation. For example, you may affirm, "Good for you that you've decreased your tobacco use by 1 cigarette a day. It says a lot about your commitment to living tobacco-free." Focus your affirmations on what you know is a person's strength in a way that really leads towards positive change. In order to build confidence, your affirmation must be genuine and also congruent with the person's experience. And finally, it shouldn't be overused. A little really goes a long way. Okay, let's look at this scenario. Trudy smokes. She knows it isn't good for her and is tired of people, like her husband, reminding her of it. Over time, she has come to realize that her social habit has become a full-fledged addiction. At some point, she knows she will stop, but just not yet. Indeed, with all the other things happening in her life, this is the one thing she does just for herself. She feels guilty about it and tries to hide it from her son and avoids the topic with her husband. She knows he's right when he brings up his concerns, but it still makes her feel angry. Take a moment to consider the strengths that you see in Trudy that you would want to highlight. All right, well, some strengths that stand out to me are, she is obviously aware that her smoking is addiction. She has insight into her current level of readiness to change, which is not just yet. And she also knows that she uses smoking as a way to cope and engage in self-care. Now on to reflections. When reflections are used skillfully, the person's self-awareness naturally deepens. In an environment of non-judgmental acceptance and understanding, people feel safe and supported, free to let down defenses and speak honestly about all aspects of their behavior. Also, people sometimes are amazed when they hear their own words restated. It is almost as if they are hearing them for the first time and had not been aware at all of their own wisdom. So there are two types of reflections, simple and complex. Simple reflections involve reflections that include the words a patient has just spoken. It could be as simple as just repeating one or two words that they just said. Whereas a complex reflection involves listening to the words that are said and the meaning behind them. As you identify a theme or underlying message, you reflect this back to the patient. So let's think back on Trudy. An example of a simple reflection would be, you're tired of being reminded that smoking isn't good for you. An example of a complex reflection would be something like, you do a lot for other people and you want to do something to take care of yourself. Our reflections are one of the most powerful interventions you can use. Whereas questions cause a person to think, reflections encourage a person to connect with their feelings and experience. Now let's read the following statement for Trudy. I've been saying forever that my smoking is just a habit, but I know I'm addicted, and that is something about myself that's been really hard to accept. What reflection statement would you respond with? And take a moment to consider your response. So some sample reflections that I came up with include, you really know that your smoking has become more than a habit, and that's hard to accept. Or, it's difficult to see that the picture you paint for the world is different from the one you see when you look inside. And the last one, you've been saying something you know is not true, and that's not how you want to be. You want to be honest with yourself. Often when people are talking about their experience, they are not completely aware of what they are saying. As such, it can be very illuminating for them to hear their words coming from you. This is where the summaries come in. Summaries are basically a collection of statements the person has made that you've linked together. Summaries can be used to help with transitions in conversation or after the patient has provided a lengthy description to you. You can also link them together, which can point out a person's ambivalence. An example of this is, on the one hand, I hear you saying that you want to stop smoking, and on the other hand, you question whether or not you can be successful. You want to know how you can achieve the success you want. Summarizing is like reflection, but includes content from several statements rather than just one or two. It's very helpful to focus your summaries on an individual's change talk. Remember that change talk involves statements made by an individual that advocate for change. Think about these change talk summaries as a bouquet of flowers. You pluck each beautiful flower from the conversation with an ambivalent person and present it to them as a bouquet at the end. There are several strategies you can use to evoke change talk from patients. The first uses the DARN acronym: desire, ability, reasons, and need. To evoke desire, use verbs such as want, wish, and like to ask about desire for change, such as, do you want to change your tobacco use? To evoke reasons, to evoke ability, ask questions about what a person is able to do or what they could do, like, what do you think you might be able to change? To evoke reasons, explore specific reasons why a person wants to change. Ask, what would be the benefits of stopping your tobacco use? To evoke need, use language that expresses an urgency to change without giving any specific reason, such as, how important is it for you to stop your tobacco use? Observe the importance of using language that is open versus language that forces someone into a position they don't want to be in, such as, why are you still smoking? Or why haven't you changed? Another strategy for evocation is by using a ruler. Here we have an importance and confidence ruler. When you use a ruler, it's a way to take a need question, such as, how important is it for you to stop using tobacco, to the next level. With a rating between 0 and 10, ask the individual to indicate how they would rate themselves on the scale right now. While it is useful to know where a person is right now, it's also helpful to ask, what makes you say a 5 and not a 3? This question encourages conversation about why change is important. I want to point out here that when you ask the opposite question, which makes you say, what makes you say a 5 and not a 7, asking in this direction encourages what we call sustained talk, which is talking about the reasons they aren't ready or don't want to change. As you can guess, this type of conversation isn't as helpful in moving people in the direction of change. Other versions of this ruler are confidence, as you see here, readiness for change, and control scaling questions. Some other strategies to evoke change include querying extremes. If someone does not demonstrate a desire to change their behavior, it can be helpful to look at what is the worst or best thing that could happen, or potential long-term consequences and opportunities. An example of this is, imagine you continue to smoke. What's the worst that can happen? Or looking back, sometimes you can elicit change talk by looking at times before the problem emerged and compare it to the current situation, such as, do you remember what your body felt like when you stopped smoking before? Looking forward, envisioning a changed future can elicit change talk. Similarly, envisioning a future in which a change has not been made can also increase motivation to change. Here's an example. If you decide to stop smoking, what do you hope will be different? Exploring goals and values. Examining what matters most to a person can not only engage a person, but can also highlight the discrepancy between their current behaviors and their goals and values. An example of this is, what matters most to you in life? And here are just a few more. Reviewing past successes. Exploring changes the person has successfully made in the past can be a source of hope. This process can help the person to recall strategies that worked. For example, when in your life have you made up your mind to do something and succeeded in doing it? Personal strengths and supports. Helping a person identify personal strengths and supports they use to make other changes can boost confidence in future success. Focus in particular on strengths and supports that are generalizable to the current situation, such as what strengths do you have that can help you quit smoking? And finally, hypothetical change. Discussing a situation from a hypothetical stance can encourage creativity and help the person think about or think from a different perspective, especially when someone is bogged down in the realities of the current situation. Here's an example. Suppose you did quit smoking and are looking back on it now. What is most likely to have worked? The power of MI lies in the way MI skills and strategies evoke change talk from an individual. The more firmly a provider voices arguments for change, the more firmly the patient may push back against considering change. Given this, you want to create opportunities for the patient to voice their arguments for change. This is really where your power lies. So to summarize, MI is a combination of an engaged understanding of the individual's internal frame of reference, a clear focus on change, and evoking an individual's own motivation and ideas for change. At BHWP, we've recently created Conversations for Change video series demonstrating an MI intervention for tobacco cessation, MI microskills, and the 5 A's for tobacco cessation. If you're interested, you can find it at our website, bhwellness.org, under Resources, then Videos. There are also corresponding worksheets you can download to use with the videos. All right, so we're at the Q&A time, and does anyone have any questions?
All right, but if you do have any questions, be sure to either use the raise your hand function, and that way we can unmute you and then we can hear you, or, and this might be a little bit more preferable if you just want to use the chat or question boxes in the control panel, which is probably set up to show up by default on the upper right-hand corner of your screen. If you have closed that, there's an orange arrow at the top of a sidebar that can be used to open that control panel up, and then you'll see the box that says questions or the box that says chat, and you can just type those right in. Okay, well, if there aren't any questions, I guess we'll just move forward. Okay, I know that this, when you sort of just scan it, looks awfully intimidating and very scary and very complex, and I'm sure that if somebody were to give me the wherewithal and the time, I would just spend an hour talking about just this, so I'm not going to do that. Instead, I'm going to direct you to our, we have a tobacco clinic workflow tool guide that's available on our set, free to download. Mostly the point of this slide is to point out that we understand that especially in very many clinics, time is of the essence. MDs in particular are reluctant to begin an MI process because they feel like it's going to take them, hours or days that they just don't have to engage clients. And that's not what we want necessarily to happen. We want tobacco cessation workflow to be included, or we want tobacco cessation services to be included across the entire workflow, so that at every point throughout the typical clinical experience, a patient is getting the right intervention at the right time. So if you think back to the 5A's process, both the introductory webinar that we presented 2 months ago and also the slide that Dr. Morris mentioned earlier in today's presentation, the MI sort of fits into the 5A's process. And that begins when the client walks through the door. And at that point, maybe there will be posters or educational material that's going to be aimed and targeted at those who are in the pre-contemplative or contemplative stages. Then they're going to get assessed. They're going to get asked and assessed, potentially initially by that intake person at the front desk. Are you a smoker? Yes or no? And potentially even more in depth, how many cigarettes per day are you smoking? When is your first one of the day? As they move into the actual clinic where they're starting to talk, getting their vitals taken, they're talking to the doctors, that's when we start to explore, we start to make that advice move, right? And then finally we move into this idea of assessment. And at that point, they've talked to the doctor, maybe they've come back to a nurse practitioner, a physician's assistant, somebody who can spend a few minutes exploring with the patient what their history of tobacco use is, what their motivation for quitting is. And that's really where those MI skills are going to start showing up. So what you're seeing here is where that happens. Where does MI really take place within a more elaborate workflow status? And you'll see that far right column is the physician, and we're really only expecting the physicians to do what we call the 2 A's in our model. That's ask and advise. Are you a smoker? We think that maybe you might reconsider that, and then referring back out. And we'll discuss in future presentations what we mean by referral, but it's suffice to say today that referral means outward to community-based resources or quit lines, but then also potentially internally back to a physician assistant, a nurse, or a tobacco treatment specialist. So with that in mind, I do want to direct you back to our website because we have just a ton of free resources available for download there, including this one, the Tobacco-Free Toolkit for Healthcare Providers. We offer most of our toolkits in English and Spanish, and we have several designs specifically for targeted populations, including criminal justice and youth, among others. Excuse me. As I've already mentioned, today's presentation was designed as the public portion of an intense 6-month learning community. In addition to the 6 public webinars already discussed, the Build a Clinic program engages practices staff in 6 exclusive live collaborative sessions with up to 15 practices around the country using the innovative eco-distance learning model. It also engages those practices in 3 individualized technical assistance calls. The webinars, ECHO sessions, and TA calls all benefit greatly from the support of ECHO Colorado's crack team of educators and the expertise of the University of Colorado's Department of Family Medicine. Doctors Matt Simpson, Chandra Brown-Levy, and Liz Wilson are all highly knowledgeable about the challenges practices face in the field as they attempt to accommodate these well-known clinical best practices for top-notch care. Please email us if you're interested in potentially joining us for a future session. We look like at this point we think that we're going to be starting an additional session around October, but the call for applications will go out in late summer. The Behavioral Health and Wellness Program is proud to be one of 3 partners providing network support, content, and program evaluation services for the National Behavioral Health Network for Tobacco Control and Cancer, a CDC-funded effort to reduce disparities in health outcomes in the behavioral health community in these 2 areas. NBHN is a network for anyone working in either tobacco control, like you all are, or cancer treatment, and especially for those who wish to know more about integrating these services. As we all know by now, tobacco is a major contributor to several cancers and is the #1 cause of lung cancer, responsible for more than 80% of lung cancer cases. In essence, tobacco cessation work is cancer prevention work. NBHN provides a national network of individuals and practices working in this realm and offers a constant stream of high-value educational content and group learning opportunities. One of our key partners in NBHN is the Smoking Cessation Leadership Council. They're doing groundbreaking work in the development and implementation of tobacco cessation interventions and related areas, and I highly encourage you to check out their website as well. ATTUDE members, ATTUDE stands for the Association for the Treatment of Tobacco Use and Dependence. It's a pretty lengthy title, so we like to shorten it to just ATTUDE. ATTUDE members are tobacco treatment specialists and other professionals who are interested in providing evidence-based tobacco cessation services. ATTUDE represents a wide number of disciplines, both in the US and internationally. As a new TTS, you will find the ATTUDE Lister to be a great source of up-to-date discussions and expert information, and they also do accreditation for TTS training programs. There are 13 such programs across the nation, of which we are one. And so if you're really thinking of ramping up services in this area, we definitely encourage you to look toward adding a TTS to your programming and look for an ATTUDE accredited program. We have a TTS course beginning this month, which is probably short notice for most of you, but we have another round coming up in October. It will be held here in Denver. The program is 3 days of intensive instruction, followed by examinations on the 4th day. If this sounds like something you might consider, send us an email with your questions. We'll be sure to get those answered. You can check the ATTUDE website mentioned on the previous slide for other programs and locations and dates, if for some reason you just don't want to come to our beautiful city. And that wraps it up on our end. So I'll just call it out for one more time. We have about 10 minutes left if anybody wants to send in any questions.
Oh, I can do it. All right, looks like there's a couple of questions. Okay, Dolores.
Okay, Dolores, it might be easier if you just type in your questions if you're not, because we're not able to hear you if you're talking. I'm going to go ahead and move on. We do have a question about whether or not any of this will be available after the fact, and yes, the answer is yes. If you go to our website at bhwellness.org, you'll see a materials tab, and under materials, you'll see a section called Build a Clinic. And on that page, we have a variety of resources that are specific to the Build a Clinic program, and that's also where all the webinars will show up, both the video version, so this what you're sitting through right now, as well as a PDF version of the slides. We do have a question about the TTS training in May. Yes, I did not say that one was open. We can't accept any more people into the May one, can we?
I don't know if you'd really like to come next week. We might consider it. So give us contact Sarah for more information.
Yeah, Greg. So if you're still on, give Sarah Mumby an email. We might be able to fit you in. As for now, we are saying that one is closed. We did fill up pretty quickly on that. But do look for potential training in October if that one fits. Not to toot our own horn too much, but we really do love our TTS training program, and we think it's one of the best ones out there. But there are other organizations that are offering those throughout the year, so check that ATTUDE site as well.
Okay, it seems like Jerry has a question.
Jury 6, thank you.
Oh.
Do you want to take that one? Which one? Acceptance and commitment.
Yeah, so someone's asking about acceptance and commitment therapy and how it dovetails with MI. And I think most people who work from the MI approach also resonate with ACT. And I think it's a very nice parallel process. I think in terms of the details, I won't really be able to go into that here. However, I very much, a lot of the people that I know, especially psychologists who have been trained in MI, have also been trained in ACT. Okay.
All right. Hold on. So Dolores is asking, she says, in my experience, it seems to take longer and more sessions to talk about an issue like smoking. How do you keep the client engaged and not bored to keep talking about the issue?
Well, I think what's really important is to talk about what's meaningful to each individual. I think, anyone who smokes, and whether they're considering quitting right now or not, has given it a lot of thought. And so likely they will not be bored talking about their smoking and their desire to quit and working incrementally towards change. And I think that exploration and your ability to show interest in them will really go a long way.
All right. One final call. We have about 5 minutes left. If anybody wants to chat in any questions for us. Okay. All right. Well, everyone, thank you very much. And once again, this will be available online at the very latest 2 weeks from today.
Thank you so much, everyone.